The lecture for today will be about the non-odontogenic pain. The previous lecture we discussed the odontogenic pain, which means the pain that is caused by a dental. So this scheme just showing you the oral and the extraoral cause of pain. The oral, it is the odontogenic one that's related to the tooth, and the other one is the non-odontogenic. The source of the odontogenic toothache maybe it is musculoskeletal one or a neurovascular. Mostly well known is the headache disorder, neuropathic pain. Some pain could be a psychological in origin, and others are related to pathological process. I will not mention them because mostly they are related to some masses or pathological disorder or some benign tumor that presses on the nerve ends or on the nerves that innervate a certain region in the face, and it causes pain. So we will forgot to tell you that diagnosis of such cases is challenging to the dentist. Yes, he should use all the knowledge that he have to give a good diagnosis, to differentiate between the odontogenic and the non-odontogenic conditions. He should get use of all his knowledge. Plus, he should use his diagnosis tools and a good history from the patient. Otherwise, he will misdiagnose the case. So to prevent such things, he should go back through all his knowledge, okay, to give a good and proper treatment plan. And if there is any need for a referral, he should refer. In this subject, going through the literatures, you might find some two names for the same disease, two different names but having the same meaning, and these names are used interchangeably. For example, a phantom tooth and atypical odontalgia. This is normal. For a chronic pain, the orofacial pain, we have either they are musculoskeletal in origin, or a neurovascular in origin, or a neuropathic. We will talk in details about each one of them. The musculoskeletal one and the somatic pain. This type of pain mostly is diffused, constant, dull, aching sensation. Okay. Such a pain, the dentist might be misdiagnosed the case as a pulpal pain. Another misleading symptoms from the patient when he tells you that he have some pain on chewing. Okay, so a good diagnosis to the muscle of mastication, especially the masseter one, can give you a clue that this pain maybe is triggered by contraction of the masseter muscle rather than having anything wrong with the periodontal ligaments. Okay, percussion can help. A good diagnosis for the tooth again can help. So by diagnosis, just a palpation for the muscle of mastication, the patient can tell you where the pain is, while in percussion there is no pain. The past one. The muscles of mastication, as we know, the main are masseter, temporalis, lateral pterygoid, muscle of the neck, Okay, there are some deep structure, non-musculature, also might cause the pain. As a dentist, a pulp test here is important, percussion, palpation, and if all of them they fail for in diagnosis, we can give an infiltration anesthesia to the region if the tooth is already anesthetized and the pain is still there, which means that it is muscular. A pain from the sinusitis, from sinus and nasal mucosal origin. Such a pain is dull, aching, and burning. This burning is typical for visceral mucosal pain. We can check the history. History here is important because such a pain or inflammation in the sinus could be viral, could be bacterial, could be allergic, and it's always associated with congestion of the nose and some nasal drainage. A good history from the patient is needed. The anatomy, yes, the upper maxillary teeth especially are very related and close to the mucosa of the sinus, the upper maxillary sinus, the shredding membrane. Any inflammation and swelling can cause such a pain. So it is a deep visceral-like tissue, sinus, nasal mucosa pain. They can induce a central excitatory effect, such as secondary hyperalgia, referred pain, and autonomic changes. So clinically, it's just a concentric spread of pain beyond the area of tissue energy, and it causes tenderness in the mucosa of the maxillary sinus, and the teeth at the area also they will be tender to percussion. Okay, but it's not including one tooth, it will include several teeth. So here it's very clear that the relation of these teeth would. So the teeth are tender to percussion, to palpation. Maybe the dentist will misdiagnose that with periradicular inflammation. And autonomic sequelae may be edema, erythema in the area by the dentist during palpation. It will might be misdiagnosed with a dental abscess. So etiology for pulpal, therefore periradicular pathosis is absent, so we have to check the tooth then. Okay, and a good history from the patient can really help. Salivary gland pain, it's expected especially when the mandibular branch of the trigeminal it innervates the salivary gland in that region, so they are related. A problem in the salivary gland is always associated. The patient will come to you asking for help because of the pain in the mandibular teeth. So a history at this clear can really help. Now secondary, we have the neurovascular pain. The neurovascular pain mostly is associated with headache disorder, and this headache mostly is from non-odontogenic origin, not associated with the toothache. Okay. We have either migraine, tension type of headache, and cluster. For the migraine, it's mostly in female than male, and the pain of the headache mostly is unilateral, pulsating, inequality, and pain is from moderate to severe and it lasts from 4 hours to 72 hours. Patient might experience nausea, vomiting, photopia, and sometimes hypersensation smell. So it's completely different from toothache, from headache, okay, and may partially or fully abate suddenly. Anyhow, the treatment that is used for such a case are also the non-steroidal anti-inflammatory medications, similar to the toothache. And this picture here can show you the difference. Here in the headache, normal headache, pain is not localized. In migraine, it is localized unilateral. Okay, it will affect the vision, light sensitivity, and heighten the sense of smell. With the painkiller, the pain will not stop. It might cause nausea and vomiting. None of these are there with the headache. History from the patient. Here comes number one. Tension type of headache, and most of us we have it. It's about 41 to 96% of the people they have such a headache, but we have to differentiate between them. Between the migraine, the unilateral one that causes nausea and vomiting, and the photophobia, while the tension headache does not cause that. Okay, and the pain is generally mild, and it lasts from 30 minutes to 7 days. Bilateral, and the feeling here is as if something is pressing on the head. And with more physical activity, this pain increases. Cluster headache. Cluster headache is a disaster because it comes frequently, sometimes 8 episodes per day or once every other day. Okay, such a cluster headache or other trigeminal autonomic cephalgia are very rare. Thanks God for that. They are neutral and they are epilateral autonomic symptoms. Sometimes, yes, at the same site of the headache, you will find some nasal congestion, rhinorrhea, lacrimation, eyelid edema, preorbital swelling, facial erythema, ptosis, miosis. All of that is expected at the same site of the head. This slide can show you the different type, the location, the pain. In sinus, you can see it's diffusing in such a way. In the TMJ, sometimes it's confused with the ear even. Cluster headache, it's around one eye. Tension headache is like a band squeezing the head. In migraine, it's unilateral with nausea and visual change. Sometimes spasm in the neck also can cause a headache. The third type is the neuropathic pain. The neuropathic pain is a pain that arises when there is a defect in the neural structure. So that's why it is a neuropathic. The type of pain on diagnosis, always it's in the area or the structure that is innervated by a certain pain. That is why the dentist have really be aware, and it is really a demand that a dentist should have a good anatomy and the distribution of the nerves. Neuralgia, like the trigeminal neuralgia, and it is intense, sharp, shooting pain, and unilateral, ipsilateral too, that precede location of the symptoms in the same area. This type of pain have a trigger somewhere, and that trigger is always in the area is well innervated and at the same site of the neuralgia. So because the lips, the gum, the teeth are well innervated, maybe they are the cause of the trigger. Patient. that and the patient will again come to you as a dentist. He is suffering from pain on chewing. So it is a good challenge for you to know. Okay. Checking intraorally if you find some dental origin like large restoration, dental trauma, recent dental treatment, that really can help in diagnosis. If there is nothing, think about the trigeminal neuralgia and be aware of the distribution of, because the pain will be there. Then we have the psychogenic toothache. The psychogenic toothache. It is similar to the patient. The pain, it looks like the patient who is suffering from psychological problem. He will be diffused, he will be vague, he will be non-localized. So this is also the type of the pain. He will be confused, but the pain will be diffused. He will be a vague personality, so it's difficult to understand. Even the psychogenic toothache will be vague, non-localized, sharp, stabbing, intense, with sensitivity to temperature change. So, because of the similarity of such a type of pain with odontogenic pain, so it needs a good diagnosis. Okay, you should use that you have and you know to differentiate. We have atypical odontalgia, pain or phantom tooth pain. These are also neuropathic orofacial pain. They are characterized by a chronic pain in a tooth or teeth, and mostly they are associated on a clinical examination are associated with a multiple extraction of a teeth on that area, or you can check or an endodontically treated teeth, because the pain may be spread to a wide area of the face and the jaw. The dental treatment mostly does not help, and it will not reduce the pain, only maybe a temporary. The pain will be will return again. So they need certain type of medications like the tricyclic and other drugs that are used for chronic pain conditions like the gabapentin, pacolfin, and duloxetine. Mostly, for me, I don't prescribe for them. There is something called hot tooth. Hot tooth mostly is associated with a tooth that needs endodontic treatment. And for such a tooth, even if you give anesthesia, the patient will feel good, and even he will still suffer from the pain. So the differential diagnosis for the odontogenic and the non-odontogenic pain is challenging to the dentist. Once patient comes, a careful intraoral diagnosis is really needed. A careful extraoral look. You should look to your dentist. Is the face symmetric or is not symmetric? All these notes should be written. A good history is needed. Intraorally check for a fracture, for caries, for defective restoration, because maybe this headache is related to odontogenic pain. Sensitivity, percussion, maybe the pain from mastication, muscle of mastication. Check if it is unilateral, localized. Is it relieved by local anesthesia? If it is, okay, these things are important. And most of the non-odontogenic pain, the patient can come to you either telling you that he is feeling some tingling sensation, shooting, burning, non-localized, cross the midline, okay, maybe joint pain, maybe muscular pain, maybe emotional stress. So a history from a patient first, then check the history of multiple extraction in the same region and some endodontic treatment. Okay, maybe the patient seek for such things to get rid from the pain. This is the last slide. I think it is also some list for the odontogenic pain and non-odontogenic pain. Okay, for your listening.